Welcome to the Future of Food is Medicine Research. My name is Merlene Tucker, and I'm here with my colleague Jeff Bornstein. Together, we'll be running this Dialogue for Health web forum. Thank you to our partners for today's event, Harvard Law School Center for Health, Law, and Policy Innovation, the Food and Society Program at the Aspen Institute, and the Walmart Foundation. Now, let's go ahead and meet the moderators of today's event, Sarah Downer and Corby Cummer. Sarah is the Associate Director of Whole Person Care at the Center for Health Law and Policy Innovation at Harvard Law School. Corby Cummer is Executive Director of Food and Society at the Aspen Institute, a senior lecturer at Tufts Friedman School of Nutrition Science, and a senior editor of The Atlantic. Welcome to Dialogue for Health. Corby, the mic's yours.
Good morning and welcome all. We're delighted to open this discussion today with a lineup of fantastic speakers, all here to talk about the concept of what we call food as medicine and the critical importance of developing and supporting more research in the food as medicine field. I'm Corby Cummer, ED of Food and Society at the Aspen Institute, Senior Lecturer at Tufts Friedman School of Nutrition Science and Policy. Today, my extremely esteemed colleague, Sarah Downer, of the Center for Health Law and Policy at Harvard, are delighted to celebrate with you the release of the Food as Medicine Research Action Plan. You'll find a link to the action plan in the Q&A. And we'll repost a link periodically over the course of today's webinar for easy access. The action plan, as we'll be calling it today, is a project 2 years in the making, guided by an incredible board of expert advisors drawn from academia, the healthcare sector, social service providers, government agencies, philanthropy, and retail, informed by many additional voices and perspectives from all across the country, and supported with enormous generosity and patience by the Walmart Foundation. We're hugely grateful to everyone who came together to help create the action plan, and we hope that you'll read it and share it with colleagues and be part of acting on its findings and its recommendations. I'll add here that I'm personally hugely grateful to Sarah Downer, a remarkable collaborator and person. Her insights, energy, and leadership inform every page of our action plan. First things first. What's food and medicine? Who'll join us here? When we talk about food as medicine today, we're referring to the way our US healthcare system responds or could respond to extremely high rates of chronic disease. The growing understanding of the fundamental relationship between diet and health, coupled with emerging research, shows us that we can influence health outcomes by using the healthcare system as a point of access for healthy food. Now, this isn't what the healthcare system normally does or is set up to do, but the many people, public agencies, academic institutions, and healthcare payers whose work informs our action plan have created pockets of incredible innovation that show what we stand to gain by expanding access to healthy food within the healthcare system and then beyond. The research action plan is a synthesis of what the food as medicine research tells us today and a blueprint for building on that evidence base so that we can quickly move from experimentation to action to access. We'll start our conversation by establishing what's at stake in the food as medicine movement. Food as medicine research action plan is, yes, about research, but it's about research that serves people. Research with an explicit end goal of putting more food that supports health into the hands and onto the plates of those who need it. We're fortunate today, extremely fortunate, to open today with remarks from a member of Congress who's an undeniable champion of nutrition access and food as medicine, Congressman Jim McGovern. Congressman McGovern will be followed by Vanessa Georges, who'll describe her experience receiving medically tailored meals during a challenging health diagnosis, in conversation with Jessica Birch from Community Servings, the organization that provides her those meals. With a better understanding of what's at stake in the policy front, we'll then have Dr. Hilary Seligman provide the perspective of a clinician and food as medicine researcher. Pam Schwartz of Kaiser Permanente will reflect on the value of food as medicine research and innovation for the healthcare sector. Following Hillary and Pam, we'll recenter our conversation again on why this really matters, with remarks from Katie, a participant in the Fresh RX Nourishing Healthy Starts Meal Kit program in St. Louis, Missouri, and Trina Regain from the nonprofit group that administers her program. It's a packed agenda, but we ambitiously plan for a generous Q&A period at the end of our discussion. Very much look forward to hearing from you. Please do send us your questions as we go along. Moderators are standing by to collect them. Now, I'll turn to Congressman Jim McGovern, who represents the 2nd District of Massachusetts, serves as chairman of the House Rules Committee. He's been a tireless champion of smart nutrition policy for decades. He's an inspiration to the food as medicine movement. He's a personal hero to me and many of you. He's the co-founder of the bipartisan Food as Medicine Working Group, and in the past year alone has introduced numerous bills related to advancing access to food as medicine interventions. He also initiated hearings and convened roundtables, always carrying the message to his colleagues on Capitol Hill: the time to act is now. With gratitude and excitement, we welcome Congressman Jim McGovern.
Well, thank you very much, Corby, for the very generous introduction. I'm delighted to be with so many friends on this call here today. And I want to thank the sponsors for gathering us here as well. And I want to thank all of you who have worked to put together this action plan. This is important. This is a big deal. We're getting closer to the turning point of treating food access and nutrition as critical parts of our healthcare system. And this plan that so many of you have worked on will help provide clarity and focus for where we need to go. Food is medicine. It seems obvious. My grandmother, when I was growing up, used to tell me an apple a day keeps the doctor away, and it would annoy me. I wish she was still alive so I could say, you were right. There is no doubt that what we eat plays a huge role in our overall health. My wife, Lisa, works for a group called the Prevent Cancer Foundation, and we have had discussions and we've been reading articles about the linkages between certain foods and cancer. So there's a lot of discussion and research that's out there for us all to digest. Yet our federal policies are decades behind the science on all of this. We prioritize treatment instead of prevention by relying on costly hospital visits and expensive prescription drugs instead of addressing the underlying issues that lead to chronic conditions. And fortunately, there has been some movement in Congress to help bring this issue to the forefront. I've worked with my colleagues to establish the Food as Medicine Working Group within the House Hunger Caucus, with the specific aim of educating my colleagues and their teams about this important issue. I introduced a resolution calling for medical schools to include nutrition education as part of their curriculum, and introduced legislation that would set up the first Medicare pilot program to bring medically tailored meals into the hospital treatment protocol. It really is astounding to me, given what we all know and given the research that already exists, that there's a disconnect between our health system and nutrition. I don't quite get it, other than the fact that sometimes it's just hard to change systems. If you've been doing something the same way for 100 years, even if it's not the best practices, sometimes it's hard to change systems and change priorities within those systems. But we need to do that. Over the last year, I have worked in a bipartisan, bicameral way to call on the White House to host a conference on food, nutrition, health, and hunger to finally break down silos and bring an interagency approach to addressing some of the most critical problems we see in our food and healthcare systems. I've been calling for this conference for a long, long time. What prompted me to do that was the fact that I have encountered too many people who are hungry and food insecure, not only in my own congressional district, but all across the country. And it seemed to me that we needed a plan to actually end hunger in this country. We have lots of programs to manage it, but we should figure out how you end it. But in the course of exploring what is out there and some of these ideas, it also became apparent to me that if we're going to end hunger, it's not just about putting food on the table for people. It's about the kind of food you put on the table. That if you want to end hunger, we ought to, and food insecurity, we ought to end nutrition insecurity as well. We ought to understand the linkages between the food that we eat, that we provide people, and their overall health. We know that kids who have good meals are more alert in school. They can learn better. They have better academic performance. We know that workers who miss meals on a regular basis, or who do not have access to nutritious food, are less productive in the workplace. And we do know, based on all the science, that diseases like diabetes and heart disease and high blood pressure, are oftentimes diet related. And yet, despite all this knowledge, we're still not connecting the dots. And so I want this White House conference to pull everybody together, to utilize the recommendations in the action plan, to call on all of you to help us connect the dots. Because if we're going to be talking about hunger and food insecurity, which I think is a moral outrage in this country, the solution is not just expanding our SNAP program. The solutions, that's maybe part of the solution, but we also need to engage every other agency. The Health and Human Services Department ought to be out front and center on these issues. And the reason why research is so incredibly important is because people use that as an excuse to not do anything. I've been trying to have conversations with the Congressional Budget Office about the cost savings that are involved if we implement policies that are more responsive to nutritional needs. Medically tailored meals when you leave a hospital setting can help keep you out of the hospital and help you get better. Food prescriptions can play a role to help prevent you from getting diabetes or better control your diabetes. And I'm always told, well, it'll cost X amount of dollars. But I say, but I think we can show you that by keeping people out of hospitals, for example, we will be saving money. So we shouldn't have to find offsets to be able to move some of these policies forward. And they come back to me all the time with research. We don't have enough research. There's lots of research out there. Many of the people on this call have done research. We have sent all of your information to CBO, but I've come to learn that is the excuse that is constantly being used to not move forward. We're going to take that excuse away. None of the work that I'm trying to do is possible without strong research and experts advocating for its importance. And time again, I'm told, as I said, we're missing more research on these issues. So I again want to thank this group for putting together this plan. I am excited to be able to bring this action plan to my colleagues on the Hill to help move even more legislation forward that supports imperative integration of food into our healthcare system. Let me just close by saying, look at what we're trying to do here, what we're advocating for really is a no-brainer. We all know, and I think everybody knows instinctively, that what we are trying to do is the right thing. Policymakers know that. We just need to give them a push. And that's one of the reasons why I'm calling for this White House conference. I say to people all the time that issues of hunger, food insecurity, and nutrition insecurity, they are essentially political problems. I mean, we know the answers. We have the resources. We have the infrastructure. We have everything. We have lacked the political will. I think this is a year in which I think we can muster the political will to make some real progress on these matters. And to all of you, I am eternally grateful. This is incredible work that you've done. And I look forward to, again, sharing all that you have concluded with my colleagues and continuing to work with you as we move toward this White House conference. With that, I yield back.
Yield back from a congressman. I'm so excited. Thank you very much, Congressman. I think we have an even clearer understanding of the urgency and opportunities of this moment And we really hope that the research action plan can be part of helping to advance your great efforts on the policy front. Let's shift from policy to what's at stake personally, with Jessica Birch of Community Servings and Vanessa Georges, a participant in Community Servings' Medically Tailored Meals program. Jessica is a registered dietitian nutritionist and the senior research project manager at Community Servings, a nonprofit organization based in Boston, Massachusetts. She oversees all of the organization's federally funded research studies on medically tailored meals. Fortunately, there are federally funded research studies. Vanessa began participating in Community Servings meal programs following a serious health diagnosis. She was born and raised in Worcester, coincidentally, in Congressman McGovern's district of Massachusetts, and is mother to a son attending the College of Holy Cross in Worcester, which we think the congressman will also approve of. As she'll tell you, she was no stranger to the healthcare world, even before her diagnosis, having worked in healthcare-related positions for over 3 decades. Jessica, can you tell us a little about Community Servings, a group I admit is very close to my heart, having been closely involved with it since its inception? Then we'll turn to Vanessa to share her experience.
Yes, thank you, Corby. I'm thrilled to be here. So Community Servings is a nonprofit organization serving medically tailored meals across the state of Massachusetts. Our meals are nutritious and made from scratch, delivered to the homes of chronically and critically ill individuals and their families. We were founded in 1990 to provide home-delivered meals to individuals living with HIV/AIDS, and initially we served 30 people a day. Today, we're serving 875,000 medically tailored meals to 3,800 clients per year. During the pandemic, we've increased our monthly meal production by 90% and are still expanding to meet additional needs. Our team of registered dietitians assesses each of our clients' individual nutritional needs and then works with them to establish their specific meal plan. Our clients have the choice of combining up to 3 of 15 different diet options to meet their individual needs and preferences. Clients also have full access to our registered dietitians to make adjustments to their meal plans. So for example, if there are changes to their medical status, or seek out additional nutritional counseling. Vanessa has been a client of Community Servings for over a year, and I'm going to invite her to share a little bit about her experience. Vanessa, can you start by sharing with us why you first sought out Community Servings meals?
Sure. In 2018, I was diagnosed with head and neck cancer. I had a radical resection on the left side. Pretty much everything was taken out, including my tonsil and salivary glands and so forth. So during the first year after surgery, I could only swallow liquids. So what I did was I was looking for an answer of how I could eat healthy, how I could find a way to make meals or have meals delivered that would kind of improve the quality of life because I was bedridden. The impact.
Oh.
I'm sorry.
I was just going to thank you for sharing those details. They're very personal, and it's really wonderful for us to hear about that. You mentioned how the meals affected your quality of life. Can you just share a little bit more broadly about what the impacts of the meals have been on your health, and maybe some more details about how they affected your quality of life?
Yes. So the meals have affected my health in ways it's almost undescribable, but I'll be able to describe a little bit. I had no strength as far as upper strength, body strength, lower body strength. These meals started to build my muscles. These meals started to make me feel better, both mentally and physically. It's great to have someone deliver something every week and see that smiling face and have that contact, wow, I am important. Someone's delivering this, specifically for me. The quality of my life is, I went from almost not wanting to live to where now I feel like I'm bigger, better, stronger. And I want to become an advocate for others. who may be struggling with any type of issues with food insecurity in their health.
Oh, that's so wonderful to hear, and so important to hear more about your specific experience. We would just like to know if you think it's important that others have access to this type of support.
I think it's important, and I also think it should be a right for everyone to be able to access this. Our health is ever evolving. So personally, a year ago, what my diet was and what I was eating has been adjusted to what I eat today. So it's kind of revisiting that relationship, having that conversation over again to touch on any things that may have changed with your health, anything that you may like to start seeing with your meals. Again, it's a relationship. That's why this works for me. It's because of the relationship again I have with community servings.
I just want to offer enormous thanks to Jessica and especially to Vanessa for sharing your experience. And we're going to keep your words top of mind at the forefront and the center of this conversation as we keep going, because that is why food is medicine advocacy matters, right? We can be more effective if we have good research and making good policy and getting access for people at a time that they really need help with that help that they need. So my name is Sarah Downer. I am the Associate Director of the Harvard Law School Center for Health Law and Policy Innovation, where I co-lead our center's Food is Medicine policy work with my colleague, Katie Garfield. And I'm really so pleased to be able to join you all today for the release of the action plan. And I want to start with, why we put this action plan together. So I have a couple slides that I'm going to show. Here we go. So, we're going to talk about the why, we're going to talk about the how, and we're going to talk about the what. So, Corby referenced right at the opening some of the high rates of chronic disease in this country. And what the CDC tells us is that, 60% of adults have one chronic disease, 40% have more than one. The vast majority of these chronic diseases, the most common chronic diseases, are diet related. So that means diet is either influencing the risk of being diagnosed with the disease, or that diet is really critical in managing or treating it. And we saw that, Vanessa said that very, very powerfully. When it comes to a cancer diagnosis, nutrition is critical. Diet quality is responsible for more deaths in the United States and around the world than the next leading risk factor, which is tobacco use. And in some respects, when it comes to dietary quality in the US, we're not doing so great as a country. So take fruits and vegetables, for example. They're an essential component of a healthy dietary pattern, but only 1 in 10 adults is eating the amount recommended by the US dietary guidelines. And this is not because people don't know that fruits and vegetables are good for you and that they should be in your diet and that they want to eat them. This is because they can't access them for one reason or another. As a country, we spend a lot of money on chronic disease. So we spend about $3.4 trillion every year. That number is 90% of all of our healthcare costs. And so it's very expensive, and it's also really tough to live with and manage chronic disease for a host of structural reasons. And so when I say structural, I mean it's due to the policy choices that we've made in this country, for example, around access to health insurance, around access to transportation, that do not make it easy to afford medications, to get to the doctor, and to afford food that supports health. And then at the same time, we've got a serious food access problem in our country. Congressman McGovern spoke to it very eloquently, right? More than 1 in 10 households across the country were food insecure in 2020. And the rate is significantly higher for households with children, higher still for households that have Black or Hispanic heads of households, and highest of all for households with children headed by a single woman. And here I'm using the terminology that the USDA uses when they do their food security surveys. Experts believe that we're going to see these rates increase, especially as some of the pandemic support and relief programs expire. So there are far too many people, as Congressman McGovern said, in our country who lack consistent access to enough food to support an active, healthy life. And then some groups within our country are really bearing a disproportionate burden of living with food insecurity. And this is a huge problem, not only because it is, as the Congressman described it, a moral failing for a country to have rates that are this high, but also because food insecurity comes with stress, it comes with stigma, and it's really strongly linked with a host of serious health conditions, including diabetes, depression, poor health in children, heart disease, and many more. And people who are food insecure have more hospitalizations, more emergency department visits, and they're more likely to be in the top 10% and even in the top 2% of healthcare expenditures. And so even people who might otherwise be food insecure, because chronic disease can really complicate nutrition beyond just affordability and access. Vanessa spoke to this really powerfully, right? So if you have mobility issues, if there are certain foods that interfere with your medications, or you have nausea or swallowing or digestive issues, it's really hard. So on the one hand, we have high rates of chronic disease. On the other hand, we have high rates of food insecurity and complications in getting good nutrition, even beyond food insecurity. And they are to some extent, exacerbating and driving each other. And so enter food as medicine interventions. So first, what is a food as medicine intervention? We use in the Food as Medicine Research Action Plan a really specific definition of the term, and that emphasizes the link between nutrition and the healthcare system. So they include, the provision of food that support health, like medically tailored meals or groceries or financial assistance to purchase food, and a nexus to the healthcare system or a connection to the healthcare system. So basically, if you're receiving a food as medicine intervention, you're getting food or extra support for food, and you're receiving it because your healthcare care provider says that you should, or because you have a health condition like diabetes or hypertension that makes you eligible. And these types of interventions are a growing phenomenon. They're being used increasingly in our healthcare system. You heard Vanessa speak really powerfully about medically tailored meals. There are also two other main categories of these interventions that we focus on in the action plan, including medically tailored groceries and produce prescriptions. And you can see the definitions here on the slide. So there are two really exciting things to note about food as medicine interventions that spurred us to create the action plan, and then two problems that we hope the use of the action plan can help us overcome. The first exciting thing is that the use of all these food as medicine interventions within the healthcare system is growing. And that is because, here's the second exciting thing, there is some really phenomenal research out there that shows the impact of these interventions on health outcomes, and even in some cases on healthcare utilization and cost. So you heard Vanessa speak about what these interventions can mean personally. The research that currently exists starts to help us understand the implications of her experience for the broader healthcare system. And then we have two problems. And the problem is that these interventions are not broadly available. So only some healthcare organizations and insurers are using them. And that means that people like Vanessa, who might live not in Massachusetts, but in some other state, might never have access to medically tailored meals despite their benefits, even if they had her same diagnosis. Sometimes it's because of regulatory barriers that make it impermissible for insurers to offer them or healthcare providers to offer them. And sometimes it's because insurers and organizations in healthcare are not offering them, even if they could do so. And this brings us to problem number two, and the reason that we came together to create this plan. One of the main reasons we hear for both of these scenarios is the need for more information, specifically research on who can benefit from these interventions, how much can they benefit, under what circumstances, and how long might they need them. So the Food as Medicine Research Action Plan is our attempt to really answer that call for more information.
Thanks to Sarah, you now know why we created the action plan, to call for more purposeful research that builds on what we know about food as medicine so that we can achieve widespread adoption of interventions we know are effective. Here's how we did it. First, we sought the guidance of experts with a wide range of experiences and perspectives. We invited top researchers in the food as medicine field, and you see at least one on camera. When you review the research roundup that appears in the action plan, you'll see the names of many of our advisors and that they appear again and again. That's because again and again, we relied on their expertise and ideas. With unfailing generosity, they gave it to us. We also ask experts in related disciplines to join us in economics, policy, sociology, epidemiology. We wanted to be sure to hear from the social service organizations and programs that have long been delivering food as medicine interventions. Even if many of these programs have been historically separate from healthcare, the current broader recognition of the impact and value of food as medicine interventions has drawn those organizations ever closer to the healthcare system. We heard about community surveys, you'll be hearing about others. We invited and luckily got representation from important government entities, including CMS and the CDC. We sought to include the perspectives of healthcare entities that are really leading in food as medicine research and innovation. You see another on camera right now. Representatives working with the retail sector joined us. We continually hear of and welcome entrepreneurial energy and interest from people who want to help understand and build the food as medicine field. Finally, knowing there's a huge need for resource investment, we invited representatives from philanthropy to our table. With our advisory board in place, we began a series of convenings in June of 2020. These convenings included our advisors right here, as well as a broader network of people and organizations who've been working on or adjacent to food as medicine. Our convenings focused on how to center racial equity in food as medicine research, research design and methods, and on factors important for expanding access to food as medicine interventions in rural areas. These were remarkable convenings. Thanks to the pandemic, they were not in person as we had planned for them to be, but real thanks to the excitement of our advisors and participants, they created the kinds of bonds and lasting collaborations we most hoped they would result in. In between meetings, we sought additional one-on-one interviews to ensure we were hearing different perspectives. Our advisors gave us input, feedback that shaped every component, from the intervention definitions to the synthesis of current research to the 26 count of recommendations aimed at guiding research over the next decade. We have immense gratitude for our funder, the Walmart Foundation, which kindly adjusted the timeline for release of our action plan following the onset of the pandemic. Many members of our advisory board who represent community-based service organizations, in fact, saw the need for food as medicine interventions skyrocket amid shutdowns, quarantines, and supply chain issues. We've been in awe of their work over the past 2 years and are particularly grateful to have their on-the-ground experience and learnings inform our action plan.
And here is what you will find in the action plan. So to plan for the future, we know we need to fully understand the present. So first, we define and try to describe the most common food as medicine interventions as they're operating today, knowing, of course, that this is an incredibly dynamic field where interventions are evolving in parallel in some cases. Wherever possible, our definitions reflect the consensus of national coalitions like the Food as Medicine Coalition, made up of medically tailored meal providers, and the National Produce Prescription Collaborative. Second, we very much recognize that food as medicine as a concept is complicated because our food and healthcare systems, unfortunately, are extremely complicated. So in promoting the expansion and scale of food as medicine, we recognize that the thing we're recommending is utilizing a really difficult to navigate and sometimes really difficult to trust healthcare system as an access point for something as essential and deeply meaningful as food. By no means are we saying this is going to be the only access point. It's not the primary access point or even close, but still we're saying the healthcare system can be a path, one path to a basic necessity. And this really demands that research and interventions in this space be subject to a heightened level of scrutiny so that we avoid missteps and any potential harms. We already have many questions in the chat about how food as medicine interventions can encompass diverse preferences, cultures, how it responds to equity, how it responds to disparity. And so our advisors really guided us in exploring the complexity of these two systems and in developing very concrete recommendations that can help to ensure equity considerations are at the center of research design, implementation, and dissemination. Third, the action plan contains the most comprehensive analysis of peer-reviewed research on food as medicine interventions that has been gathered to date, as far as we know. Here I want to particularly recognize my co-authors and the hard work of Emma Klippinger, Kurt Hager, and Vanessa Acosta, who did incredible work on gathering and analyzing this research. Out of all of the studies we reviewed, we looked really closely, and you'll see it in the plan, at 49 studies that meet our definition of food as medicine. So our research evaluated the impact of providing food or food support on health. We want people to come away from the action plan ready to build on the evidence base, not repeat it. And because food as medicine interventions are not designed in a lab, they still largely are developed out in the community, sometimes in collaboration with healthcare, but sometimes really not. We endeavor in this plan to explain some of the key research concepts that can really help non-researchers understand how to think about evaluating programs. So what are reasonable outcomes to expect given the amount of food that you're providing? Is the research that you're contemplating going to be able to tell you what you most want to know and what will be most valuable to the people that you serve? And finally, the action plan contains 26 recommendations. We wanted there to be 25, but there were so many good things that there had to be 26, which we hope will guide and inform the next decade of food as medicine research. These recommendations contain concrete guidance on how to embed equity throughout the research continuum, recognizing that the standard practices we are employing today must shift in order to do so. We identify key considerations for ensuring that research design is robust and appropriate for yielding the most valuable and actionable information. So sometimes that means larger sample sizes with rigorous methods. Sometimes that means gleaning information on attitudes, beliefs, and behaviors about food as medicine interventions through qualitative research methods, just as important and often overlooked. We identify some of the most urgent questions that need to be explored. And the very good news is for all of the participants on this webinar that there's almost no end to meaningful inquiry in this field. And we describe how funders can support valuable research. Finally, we suggest some of the key questions outside of the field of food as medicine that have major implications for transforming our healthcare and food systems. Again, the link to the action plan is in the Q&A for you. Lots of recommendations for hypothetical future research, but how do we make them real? What does it really look like to do food as medicine research and to move ahead in this field that has gained all this momentum and traction, especially in the last 5 years? For this perspective, we are turning to Dr. Hilary Seligman, Professor of Medicine Epidemiology and Biostatistics at the University of California, San Francisco. And she is the director also of the Food Policy, Health, and Hunger Research Program at UCSF's Center for Vulnerable Populations. As that title implies, she is a nationally known expert in food insecurity and health. She founded Eat SF, a fruit and vegetable voucher program currently operating in San Francisco, and is an author on many of the research studies included and cited in this action plan. She is a key member of the Action Plan's advisory board, and we are so grateful that she can join us today. I'm going to turn it over to you, Hilary.
Okay, thank you so much, Sarah. Just one second. All right, thanks, Sarah, for the introduction and for the opportunity to highlight my own research and the research of some other people who I really admire, to give you some examples of how we put this research action plan into practice. I want to start by acknowledging that I have been asked to highlight my own work over the next 10 minutes. And my own work is neither the best nor the most comprehensive in many of these ways. I come to you as a white food secure woman. And so there are many gaps in what I'm going to tell you today, but I'm hoping to give you an example of how we start to put some of this work into practice. My own work also has been achieved in collaboration with many, many other highly skilled collaborators. I also want to say my slides are really busy. Everything in that purple box is just making reference to one specific article throughout the presentation. It's there if you want it later on, but don't need to rest your eyes on it for long. At the top of the slide, you see the section of the action plan that I'm talking about. And this, and here I'm starting with talking about equity. And I want to start by making a couple of points about our need to bring more participant voices to our work. This can be done using a community-based participatory research model. And this is really in many ways the gold standard, very collaborative, very intentional. And this approach has been used to design, implement, and evaluate many food as medicine interventions like you see on the top here, often supported by very robust community advisory boards. And this is a place where I think my own work needs to really grow and the food as medicine field needs to grow. So I show some examples on this page of some excellent work that's been performed by others. I also would like to make the point, as you can see here, that these perspectives can and must be carried through to the dissemination part of our work. And that's the stage in which we take the evidence that we generate from our research and turn it into good public policy. Many of you know a great example of this, and that would be the example of Witnesses to Hunger, which is one of the most robust examples of how we take good evidence and use it in a format that's influential for creating policy. Another way that we can more rigorously bring more participant voice to enhance our work is through formal qualitative research, and I give you just two representative examples here. The first paper on how food insecurity contributes to poor HIV outcomes gave us really important local context for understanding a food as medicine intervention in the San Francisco Bay Area. And in the one on the bottom, we use qualitative research to understand how a new policy change within SNAP, formerly the food stamp program, was being experienced in our community. And this paper also gave us some really important takeaways for food as medicine interventions. For example, the fact that food benefits, without being paired with support for transportation and support for preparing food, were very difficult for older adults and adults with disabilities to use. So an important message for our food as medicine interventions. This section of the action plan reflects the importance of household composition and household equipment. This is recommendation 9. And in the paper you see here, we followed up on a hypothesis that participants helped us generate as to why a food as medicine voucher was not helpful in changing dietary intake for some people. And in this case, the thought was that a voucher provided to a larger household was not going to be as effective as one provided to a smaller household if the value of it, the amount of the voucher, wasn't scaled for household size. Now, this point is rather obvious in retrospect, that if you gave the same amount of money to a bigger household as a smaller household, you might get the same benefit. But in this paper, we were able to show the extent to which each individual in a larger household derived less benefit from a voucher that was not scaled to household size. Really good evidence for developing our food as medicine interventions. Then on the right here, you see an example of how important it is to understand household equipment when developing our food as medicine interventions. What you see here is a study we did to understand one community of people frequently using food as medicine interventions in San Francisco, and that was people living in single room occupancy hotels. And you can see here that in the 595 people we surveyed, only 69% of them had any access to cooking equipment, and only half had cooking equipment in their own unit. So obviously this is going to be very important in designing and setting up an effective food as medicine intervention in this community. And without having this insight into the experiences of our participants, our food as medicine interventions likely would not be as effective. Moving on to the research consideration space. I've already touched a little bit on the importance of participant voice in qualitative research, But this thread really needs to be woven throughout the entire food as medicine program design process, using what we call mixed methods approaches or phased approaches, where the food as medicine program is being constantly developed and refined with the voices of participants. This, for example, is two studies, one of which I've mentioned before. One is qualitative, one is quantitative, and they looked at the same natural experiment, expansion of SNAP benefits to older adult SSI recipients in California. And really using those dual approaches allowed our interviews to inform our surveys and our surveys to inform our interviews, so that we captured a much more robust understanding of the effectiveness of these types of programs. I am moving on now to talking about the importance of rigorous study designs, and there are great examples that exist now of extremely rigorously designed studies in the food as medicine space or in adjacent spaces, such as this very well-known one by my colleague, Seth Berkowitz and colleagues, that use a randomized controlled trial design, the gold standard, most rigorous study design out there. And I want to note on the bottom there that even in this very rigorously designed randomized controlled trial, there was intentional effort to elicit patient reflections as to what worked, what didn't work, what should be changed in the future of this intervention. I also want to point out here that there's certainly an important role for randomized controlled trials in the future of food as medicine research. And I show you one of my own examples here, but this is not the only approach. And in many cases, I don't believe the randomized controlled trial is the appropriate approach, especially as we see the development and scaling of these types of programs across the country. In particular, I want to call attention to the fact that randomized controlled trials do not, as a general rule, enroll an enormous number of participants. They don't follow participants for very long. And so it's very challenging to demonstrate an impact on health outcomes, especially as those outcomes become more prevention focused. So for example, very difficult to demonstrate that a food as medicine program prevents diabetes among people with prediabetes, or prevents the development of obesity among children who are already overweight. It does not mean that our food as medicine interventions can't do them, only that they're very difficult to observe in these trial designs. And I'll give you some examples of that in just a minute. The next action plan point I want to touch on is the importance of process and engagement metrics. We often focus almost all of our evaluation efforts on effectiveness, but I want to spend a minute to reinforce this point about how process and engagement is so important, not just for ongoing quality improvement, but also for understanding the potential public health impact of our food as medicine programs. So if we design a food as medicine program perfectly for maximum effectiveness, but we don't make it work with clinical flows, or we make it so expensive that we can't maintain it, or it only reaches the most highly resourced people, it's not going to have any impact at all. My favorite structure for process and engagement evaluation is the RE-AIM framework, which helps us to focus not just on effectiveness, but also reach, adoption, implementation, and maintenance, like you see here, which is an example of a RE-AIM evaluation we did for a food as medicine intervention we conducted in collaboration with our WIC clinics locally. On the right here, you see another example of focusing on the reach part of this work. This was work we conducted with 7 food banks who were collaborating with their healthcare partners in developing food as medicine interventions. Our focus here was on process metrics and understanding key challenges for implementing these kinds of collaborative interventions, with the desire to understand the pain points so that we could be much more successful in future iterations of implementation to maximize not just effectiveness, but reach, adoption, implementation, and maintenance. Recommendation 13 focuses on the intensity and duration of food as medicine interventions. And one of the points I made earlier and return to now is an uncomfortable fact that I think we need to start addressing within our research. And that is that the intensity and duration of our programs may actually be insufficient to have a measurable impact on health outcomes. And I return to the example of my own work, a randomized controlled trial of a food intervention in the food pantry setting for people with diabetes. And in this study, we were not able to demonstrate an impact on hemoglobin A1C. This does not necessarily mean that our food as medicine programs don't work. I want to be very clear about that. It does mean that we need to study very rigorously what an adequate dose and duration is. We have to work to develop funding streams that can support a longer duration and higher levels of support. And we have to convince the funders of our research to fund these longer term studies. And here you can see an excellent example, a microsimulation model that was conducted by colleagues at Tufts School of Nutrition, which shows that we would expect it to take years for a food as medicine intervention to become cost effective or to avert negative health outcomes for someone in Medicare or Medicaid. But, and this is the key point, it does happen. It happens with great frequency. And it is highly cost effective in the long term. And this is where we need to be, have our eye focused for the future. There has been an emphasis on leveraging the insights of existing food as medicine research on healthcare cost and utilization to help drive integration into healthcare. And we have a lot of research now showing that medically tailored meals can reduce hospital and emergency room utilization and reduce healthcare costs. I show one here conducted by a colleague. This study and others like it have been very, very influential in the field. And with the caveats I mentioned previously about adequate dose and duration, these studies really should be conducted with other types of food as medicine programs and broadly disseminated to policymakers to support continued dissemination. I do think this is going to require substantial commitment on the part of funders and should not be taken on at the local level or at small scale. We have also conducted studies showing the cost of food insecurity in every county and state in the US, and the impact of SNAP on reducing healthcare costs. And these studies can be leveraged to support the argument that interventions that reduce food insecurity and support better dietary intake can save on downstream healthcare costs. In order to really integrate into healthcare, the researchers in this space are really going to have to communicate with policymakers using communication strategies that work for the policymakers. And this is much more likely to be infographics like you see here, or policy briefs, and much less likely to be academic research papers. You see here on the left an infographic on cost effectiveness of food as medicine interventions, and on the right, an infographic supporting a Medicaid 1115 waiver application in the state of California. The next phase of exploration section of the recommendations calls attention to new places we're going to have to turn our attention. The one I highlight here is co-benefits. This is the concept that food as medicine interventions may have impacts well beyond program participants, particularly when brought to scale. I show an example of co-benefit study in the physical activity space, so you can see some of these dimensions. And on the right, a study we did with Colorado State University to examine some co-benefits of an increased WIC fruit and vegetable voucher, where you see that we examined the impact on the national economy and on labor income. In the interest of time, I'm going to skip this, but just quickly mention that there are many examples of natural experiments that really help us to understand the impact of federal nutrition programs and other policies that are happening in real time. These are exceptional opportunities for researchers, but because these natural experiments are regular events happening on someone else's timeline, funders have to be aware that time is often of the essence. Funding decisions have to sometimes be made very quickly to take advantage of them. So I hope this is giving you some concrete examples of how a research action plan can help drive some of the research we need. And with that, I will turn it back over to Corby.
Hillary, our audience can see why you've been such a crucial member of our advisory board from day one, and to be honest, from before day one, because Hillary's work has long been an inspiration to me and guided the conception of this entire research action plan. So we heard so much in your remarks about how what the field is doing well, what it's still struggling with, being equity centered, well designed, and well funded to really advance the field. I'm particularly taken with the idea that it might take years for a food as medicine intervention to become cost effective, but it does happen. It happens with great frequency, and it's highly cost effective in the long term. I plan to adopt that as a key speaking point and never credit you, Hillary. Of course, I will always credit you. It's something always to keep in mind. Now, we're going to turn to another member of our advisory board, Pam Schwartz, for some reflections on what's driving healthcare organizations as large and well-respected and innovative as Kaiser Permanente to engage in food as medicine innovation and research. Pam's the executive director for community health at Kaiser, the leader of Kaiser's Food for Life initiative, which aims to transform economic, social, and policy environments so that people have access to healthy food. Pam and her team have several randomized controlled trials on food as medicine interventions underway. That shows she's both a true leader in this field and a pragmatist. We always need her perspective. Pam, I'll turn it over to you.
Thank you, Corby, and thank you to you and Sarah for having me here and having me both in the development of the action plan and also here today. And the benefit of going after or so late into the panel is I can just say ditto to a lot of what's already been said. And I'll just say a little about Kaiser as well. We have a long history of addressing nutrition and food insecurity. And like the other speakers have said, we believe that everyone in the nation has the right to the most basic of human needs, including food and including nutritious food, and that nobody can reach or maintain their best physical or mental health without those needs being met. And our food insecurity work is one effort within a larger social health strategy. And this is where we're aiming to elevate social health to the same importance as physical and mental health. And so back in 2020, we surveyed our members asking them about their social needs. And we found that over 30% experienced some type of food insecurity. And we also saw that people who reported food insecurity were 2.5 times more likely to report either fair or poor physical and mental health. And so as we were developing our food insecurity strategy, we could see that the evidence was sparse on how to best implement these food as medicine interventions. And also we saw that there's a role for healthcare in contributing to the evidence. And a big thanks to members of the panel and also the development of the action plan for being so incremental or so meaningful in the design of our strategy. We know that healthcare needs to really understand the science and also combine the science with input from the people who are really experiencing the food insecurity. So this is, Hillary said this, we need to work together to build the evidence, and where it doesn't exist, we need to help build it. And we need to do that with equity in mind, as the action plan so eloquently spells out. And so this includes things, again, like what was said by Hillary, how we partner with communities to co-create our strategy, how we launch interventions, where we launch interventions, how we design our evaluations, and also how we measure our outcomes. So we have been rolling up our sleeves over the past two or more years to really, maybe I think it's over 3 years now, to really contribute to the evidence and the food as medicine movement. And we're seeing momentum across the nation, including inside healthcare, and especially over the past year, headed more and more headed in this direction. And so there are 2 food as medicine initiatives that I want to tell you about that we've been studying. And these are both food as medicine initiatives that help people access healthy food to deal with their medical conditions. So we also do some work around SNAP, but I'm going to focus on medically tailored meals and produce prescriptions. So the first that I'll talk about is medically tailored meals. And we're now seeing medically tailored meals take hold in healthcare across the nation. And when we were designing our food insecurity strategy a few years ago, we talked to leaders in the field and we asked them what healthcare should do to address food insecurity and nutrition. And they did not miss a beat in telling us that we should take on medically tailored meals. But not only the intervention, they suggested that we should also build the evidence of what works and under what conditions. So we launched 4 medically tailored meal studies for folks who were recently discharged from the hospital with chronic conditions. And we did this back in the spring of 2020. So this was just as COVID was entering our world. And we just completed the data collection. We have over 2,100 patients receiving almost 120,000 meals at this point for both our patients and their households. And we intentionally created the studies with variations with the intention of informing the evidence. So we looked at things which Hillary mentioned, the dose and duration. We looked at the number of weeks of meals, the number of meals a day, nutrition counseling. Do we feed the household so the hungry mom doesn't give her food to the hungry child? We looked at over 65, under 65, so we could understand age. And then, of course, we looked at which disease categories lead to better health outcomes and cost savings. And the results are looking promising, and we should be able to share very soon as we're just completing the analysis of our studies. The second that I want to talk about is produce prescriptions. And I know that I don't have to tell this crowd that produce prescription is a promising food as medicine innovation. And it can help bridge the gap between healthcare and food systems with a practical, scalable, sustainable, and also affordable intervention that uses healthy food prescriptions to improve clinical outcomes and quality of life and equity. And produce prescriptions have been on our radar for quite some time. And as the paper demonstrates, the evidence is even more sparse here for produce prescription than it is for medically tailored meals. So back in November, just 2 months ago around Thanksgiving, we launched a clinical trial to test produce prescriptions by providing healthy food boxes and nutrition education to people with diabetes, many of whom are also food insecure. And we're super excited about this trial as it will not only contribute to the evidence, but also to the national dialogue, just like this one, about the role of healthy food in improving health outcomes and cost. And so far we have over 160 food boxes that have been delivered to our patients' homes. And there's lots of excitement here for our patients and also for our clinical clinical operations and research colleagues. In addition, in partnership with the Rockefeller Foundation, we're also supporting other produce prescription studies looking to further build the evidence here. So each of the initiatives that I mentioned has a robust evaluation, and as Hillary said, when possible, a randomized controlled trial, and sometimes that is not possible. But our intention is to build the science and also to understand how we might modify and scale the work moving forward. And so we're pairing this rigor with also with qualitative data as has been discussed to really understand the impact on our members, our patients, their families, and also on our employees and on the business. So I hope that you've heard me say that Kaiser Permanente is committed to building the evidence and also the business case for these interventions. And we've been trying to better understand what works and under what conditions so that we can have the greatest impact on health and cost. All of this also with equity in mind. So we've been really trying to also build the business case, at least for healthcare. And this includes things like cost and utilization data and understanding the value of these programs to our members, to our patients, and to the organization, again, including our clinical and operational staff. So really trying to build out a business case that's not just an ROI, but tells the broader story of the impact of this work on people's lives and on the way that we deliver healthcare. And as the paper suggests, we really need to learn from our members and patients what works for the people that we're trying to help. We know this, to understand the barriers, co-create the solutions. So we're trying to marry the evidence, the lived experience, the best practices, and also where the evidence doesn't exist, we're trying to leverage our size, scale, research and data capabilities to really understand the impact on health and cost of care. And recently, and you've heard this from the whole panel, there's been quite a buzz around food as medicine. And we can see that in the interest for this panel. There are a lot of people on the call today, and we have been trying to build on the momentum here. And this action plan does just that. It really moves the field forward in how we can all organize ourselves to really make a greater impact on health, and also the role that healthcare can play in being part of the solution.
Pam, I just want to say an enormous thank you. We are so glad to have you, and we are so glad for Kaiser's leadership in this space. There's so much innovation that you described, and the fact that you're really studying it in such a rigorous way, you're intentionally sort of working to co-create some of these things, and then you're going to publish it so that everybody can really benefit from the work that Kaiser is doing. We need more healthcare companies and health insurers to come to the table in this way, because we know that there's so much innovation going on, but some of that information is being held close to the vest, and we'd love to get it out in the open and be able to benefit from it. So we really do salute you and are so grateful to Kaiser for the work that you're doing and the amount of investment that you have put into it. We've also heard, I think, a couple things that you said, that you're really working with others to make sure that you can fund these research studies and make them the size that they need to be. So we heard you sort of collaborating with Rockefeller, doing your own work at Kaiser. This is all just really phenomenal. And so we really want to lift that up and say a huge thank you to you. And I'm
going to interrupt you, Sarah, just to say thank you to you and also to Hillary for helping to guide our work, because we could not do this without you. We wouldn't know what to do. So it takes a village here. Also to Vanessa, to the patients who really tell us how this is impacting them, and we're trying to do work with all of you to make sure that we're responding in the way that makes sense and creates the best impact.
Thank you. And I know that you might have to step off, so we will say goodbye to you. And then we will now we're going to turn back to, again, what's at stake if we don't get our next steps right in food as medicine research. So we're going to ask our last guest speakers today to bring us back to what equity-centered, well-designed, purposeful research can bring us. And that is more access to interventions that can really make a difference in people's health and lives. To refocus our conversation there, after we've been through the research and walking through the value in this for healthcare, I'll introduce Trina Reagan, the Director of Policy and Innovation at Operation Food Search, a nonprofit organization in Missouri, and Katie, who is a participant in the Fresh RX Nourishing Healthy Starts program that's operated by that organization. So Trina at Operation Food Search is responsible for leading education and advocacy efforts among elected officials, policymakers, and direct service providers. And she's been really deeply involved in developing the Fresh RX program and shaping its evaluation. And we've had many conversations over the past 2 years that have just really excited and inspired, I think, all of us on the Food as Medicine Advisory Board. So we're excited to have you hear about that. And then Katie, who will be joining us, is a mom of 3 who delivered her youngest daughter while participating in the Fresh RX program. She's now a member of the Fresh RX Participant Advisory Council and is joining us on her lunch break from her job in healthcare. So Trina and Katie, we are so grateful to you both for being with us today. Trina, I'm going to ask you to start by telling us a little bit about Operation Food Search and Fresh RX, and then hope that Katie can describe her experience participating in the program.
Thanks so much for asking us to be here today, Sarah. So Operation Food Search started in 1981 as a food bank, and about 5 years ago, through a strategic planning process, decided to start not only meeting that immediate need, but looking at how we could be part of working upstream to find solutions focused on food insecurity as a social determinant of health. And 4 years ago, we came across this concept of food as medicine and started thinking about how we might implement a program in the St. Louis region. Our first Food as Medicine program is Fresh RX Nourishing Healthy Starts. It's been around 4 years now. 3 months ago, we just started a randomized controlled trial of the program, working with research partners at the Social Policy Institute at Washington University in St. Louis. The program works with pregnant women through 60 days postpartum who screen positive for food insecurity when talking to either their healthcare provider or their Medicaid managed care organization. They must be insured under Medicaid for pregnant women in the state of Missouri, and they need to be 20 weeks gestation or less when they are referred to us for participation in the program, since we know nutrition interventions take a while to work. Once they are enrolled in the program, they receive weekly home delivery of meal kits. If you're familiar with things like HelloFresh or Blue Apron, it looks very similar to that, but it was developed by our registered dietitians and chefs to be nutrient dense and meet the needs of a woman during pregnancy. In addition to that, all participants have access to a registered dietitian throughout their participation and receive care management from one of the social workers on our staff, because we know food insecurity does not occur in a bubble, and often families are struggling to meet other basic needs. So that wraps up what our program looks like in just a nutshell. And Katie, are you able to hear me?
Hey,
Hi, Katie, how are you?
I'm good. How are you?
Good. So do you want to talk, I guess, just a little bit about how you came to know about the Nourishing Healthy Starts program?
Yeah, so I went to DePaul and met with my doctor. And they started asking questions about, food insecurities and stuff like that. And I was kind of hesitant because I never really had those questions over in Illinois. So I was like, why are you guys asking those questions? I almost didn't answer it truthfully because I wasn't sure where it was going and why the doctor was asking. But I took the leap of faith and I answered, and they told me about the program. It kind of threw me for a loop because I was like, well, what program is this that would like randomly give me food for free and all the support, and it's not SNAP or Link or anything like that. So then I got to meet all of you guys, and it was kind of like a family. It was kind of really cool. We got to just, I don't know, like there was food. We got to do get-togethers before COVID. We got to learn a lot. I didn't realize just how lacking my food was until I actually sat down and talked to some of the chefs. Like, I knew my food wasn't the greatest, but I also didn't know just how crappy I was really truly eating until like she sat down and showed like, hey, just because it says, oh, it's low fat, it's not really low fat, or no sugar. It actually has a decent amount of sugar in it. I also was, I'm a single mom of 3, and I don't get SNAP at all. They say I make too much money because I work at a hospital. And with COVID, I get to make extra money because I work hours because I have to pick up. And without you guys, I wouldn't be making enough food for my kids at all. I also wouldn't have support because being able to pick my food up from you guys, I get to talk with you guys and get the support. Just hearing you guys and knowing that you guys are there, it helps a lot. One thing I do miss about the program was when we got to do like the cooking classes. Elijah loved it. He absolutely adored going to the cooking classes. When he comes with me to do the pickups, he's like, so when are we doing cooking again? When we get to cook? It was just so great to like meet with other moms who are in the same situation and know that I'm not failing. Like you feel like you're failing. Like the factor that I can't afford to feed my kids and myself and provide rent for my food, like my kids, it hurts. It sucks. And you don't want to talk to people about it because you feel like a failure and you don't want to be judged and you're worried, what is so-and-so going to think? So the factor that people are actually like trying to do something to help, and they recognize that, food does play such an important role, not just for the mom, but for the baby too, is amazing because I would have given up my food, which would have hurt my baby because I would have wanted my kids to eat. And do I know that it would have hurt my baby? I totally know that. But those kids who are sitting here at my table, how could I let them go hungry? So the factor that I now have fresh meat or fresh fruits and veggies was amazing. Another thing that I loved is if it wasn't for you guys with those meal kits, Lord knows I never, ever, ever, ever would have made stuffed peppers, ever. I hated peppers. I never tried them, but I hated them. But because you guys provided them, I was like, well, crap, I have to make them. Like, they're here, they were given to me. I can't just let them go to waste. So I made them, and they're now an essential. Like, I make stuffed peppers or stuffed pepper casserole at least once a week. Like, it's now something we eat all the time. Or like black beans. I never would have thought to use black beans in like 90% of the crap that we use. And black beans now are like, they're hidden. I don't want to say this too loud because the kids are in the other room, but black beans are in like everything, including my brownies. Like, the kids don't know. They're getting proteins and fats and everything, and they don't even realize that they're getting healthy food without knowing it. Or like pancakes. Like, the chefs there and the dietitians, they have taught me how to sneak food in, like mac and cheese, squash and carrots are they're snuck into the sauce. You never would have known trying my mac and cheese. It looks just like the box mac and cheese. My son has no clue. He might now know because he's probably in there listening to this conversation. But before this call, he had no clue. But it's because of you guys, I've now learned how to be able to like feed them healthier. I now have the support, and I have the food provided for me and the recipes, because I never would have thought to like, oh, let's go online and look for ways to sneak it in. You know, it's just, you don't think about that. You're just like, oh crap, like, I'll just try to like, I'll feed them what I can, blah, blah, blah. You know, I just happened to be talking to the chef, and I was like, yeah, he doesn't like it. So it's kind of SOL. And she's like, oh wait, hold on. He likes brownies, right? Let me show you this recipe real quick. I'll make up a batch, and here you go, try it. The boy ate it. The boy ate like 3 brownies that day, had no clue, and he asked for it all the time. There's black beans in it. It's amazing.
It's so fun hearing your stories of the kids, you know, you and the kids experimenting with new foods. And Katie, you've been with us since the very beginning, and you know kind of why we built this program. And the whole idea was to make this accessible to more families by establishing the impact of the program. And so we heard earlier from the congressman, what would be your message in terms to healthcare or to our elected officials in terms of supporting food is medicine programming?
I say do it. It's dumb not to. There's so many people who need it. Like, the congressman said it himself. People don't want to talk about it. Please go put it up for me. Thank you. People don't want to talk about it because they're ashamed. They're embarrassed. You know it's out there. You do. You know it's out there, and it's hurting people. So why keep pushing it under the table? Why not take the bull by the horns and help those people? Why keep having our hospitals overrunning right now? Like, we have no beds in that hospital. I work there right now, and we're drowning. So why not grab it and start from the ground up, which is a pregnant mom? Let's start with food. Food's medicine. Screw it. Like, why not teach the kids from the beginning? Food's medicine. If we get them hooked on the healthy food, stop producing all the crap, stop letting them learn that that's the good stuff, get them addicted. My kids drink water. My 2-year-old, I gave her soda. She turned it down and wanted her water. Like, let's just do it. No more, what's the game? Why play the game anymore? Let's just do it.
I love your passion, and I just thank you so much for being willing to share your story with everyone here today. You've been integral to helping us grow the program. So thank you so much, Katie.
No problem.
Will you give me some milk?
Bye. Have a good day.
Hi, Katie. And just an enormous thank you to Katie and to Trina. I mean, I think anyone who listened to Katie understands the value immediately of this program. And same with Vanessa's remarks, right? You understand immediately, and you understand it sort of in your whole being, in a way that no statistic about healthcare use or healthcare cost or, you know, clinical outcomes can make clear why these programs are important and why we need to invest and focus on them. So we can see the urgency of making sure we expand access to the programs and, really critically expand access to them according to the feedback and input of people who are participating in them. So we just really thank Trina and Katie for sharing about that and all of the time that Katie puts into the Participant Advisory Council, the advocacy, the time that she took to hear your stories. So a huge thank you. We are almost ready to open the webinar up to Q&A. Before we do so, Corby and I just want to reflect for a moment on all that our speakers have shared, because they really have underscored to a phenomenal degree the importance of making sure that the next decade of food as medicine research is thoughtful and done with deliberation and an awareness of what is already out there in the field so that we can build on it. And we truly believe, everyone who has spoken to you today, I think believes that we are at an inflection point when it comes to food as medicine. And we want to be sure that what happens next is going to serve people. It's going to support health. It's going to be available to everyone who can benefit in a way that they can really use it in a way that meets all of their varied needs. So we don't want the healthcare system to dictate to us what's possible. We want to demonstrate the true multidimensional value of these interventions and have that data be so compelling that it changes the way that healthcare works.
So that's where our research action plan comes in. There's been incredible innovation on the ground. You've heard about it today. Food as medicine for decades has been growing. It is moving policy, especially in the last 5 years. There's much more to be achieved. A strong evidence base is what will get us there. So today you heard the powerful message from our speakers that food as medicine research must center equity. That's the first of many things we want to highlight, and Sarah's going to tell us about more.
Yes, so you also heard a lot about the importance of research design and methodology from Hillary and Pam. And I just want to say, the recommendations in the research action plan are there, and there's lots and lots of information about how to apply them. And so we really do encourage you to dig in there. And I think you're going to find a lot of what you're looking for in the Q&A. You're going to find it in this plan. We're very excited that we have answers to all of those questions, even if we don't get to them in the Q&A. So we need to know that we're asking the right questions. We need to know that we're asking the right people the right questions and in the right way. And we've got to make sure that we're designing research to be able to provide meaningful answers. So we do want to look at primary prevention, right? And Katie spoke to that really powerfully. We start young and we get people to eat healthy food, and we prevent things maybe further down the road. We want to look at that. We want to therefore do bigger studies, longer studies. We have to be thinking about these things as well.
And bigger and longer studies, what do they take? Money, funding. We need more funding, lots of it. We see lots of opportunities for leadership in this field from the NIH. We've seen an increase in funding awards for food as medicine research in the past few years, and we're really excited about it. But we also recognize that NIH can do much more, and we hope that they do, guided by our research action plan, of course. We also see so much experimentation and innovation happening all across the country, Medicare and Medicaid. You heard about that today. There's so much more to come. We want to capture more of this impact and the programs that get funded and explored in the future. Finally, we see a huge role for private funders to collaborate with government and with each other to support these bigger, longer, equity-centered research studies.
And what we want also is, to really emphasize that there are so many ways food as medicine interventions can have an impact beyond the healthcare system as well, especially if they scale. There are a lot of things Katie and Vanessa both mentioned about their experience, the value that food as medicine had to them that will spill over into other sectors. So here we're thinking about agriculture, labor practices, employment, education, social safety net, transportation policy. The more we understand about these impacts, the more we can make smart policy across the board, and the more we can avoid any unintended consequences in other areas. We also want to make sure we're thinking about the ways that we can get to the same goals, right, of better health good access to nutrition, even outside of the healthcare system. So the action plan places, our emphasis is always on the healthcare system in the plan, but we operate in context of lots of other systems. And so we have things in the action plan that speak to that.
And we want the action plan to be a departure point for more discussions, more innovation, more policy making. Most important of all, the inclusion of more voices and experiences in shaping what food is medicine can and should be going forward. So now we've got our robust Q&A, which means that we really need yet more time at another webinar. But I'm going to hand it right over to Sarah.
All right, so we have about 30 minutes for this Q&A. So I thought it might be a great thing to just talk for a moment about equity, because that has been a running theme of our questions throughout this presentation. How do we make sure that the food that's coming to people is food that they want to eat, that they, that resonates with them, that they recognize, how do we really think about that and ensure that? And I want to maybe start with Vanessa talking about sort of the kinds of food that she's received and give her an opportunity to come back and speak with us. And then maybe talk a little bit to everyone else to speak to that in the food as medicine interventions you've been involved with. Vanessa, go ahead.
All right, so growing up, I was an extremely picky eater. Pretty much ate mac and cheese. I don't know, we'll go through high school. I can't believe the meals that I'm receiving right now. One, I've gone vegetarian. I no longer eat meat. So I cannot believe of all the vegetables that I'm eating. The different types. I didn't even know what quinoa was until food is medicine. Frittatas. It's introducing me to a different culture of nutrition as well. Not just your everyday average, like nothing against McGovern, but Congressman McGovern, excuse me, but apple a day. There's so many different cultures that have their own take on nutrition as well. I'm given 5, meals. I'm given yogurt, fruit. There's these things called peanut butter balls that I put in my yogurt that have put a lot of protein in them. It's just, I'm getting the vegetables and vitamins and the strength that I need to keep on thriving.
That's amazing, Vanessa. And I just really thank you again for sharing your story. We are almost at time, but I wanted to emphasize that I think we heard from you and from Katie that some of participating in the food as medicine interventions has been exciting because you're trying new things and you feel like you're, connecting to all kinds of other ways of eating and knowledge bases, and that's really incredible. I want to give a moment to Trina or Hillary or Pam to talk a little bit about, how have you been thinking about the breadth of food, the choices that participants have in these programs?
First, thank you, Sarah. First of all, I will reinforce the point that we need more people who are potential program participants or program participants to be co-designing these interventions with us. I want to acknowledge the excellent point made by one of the webinar participants that all of us on this call are white and many of our program participants are Black or brown, and we need to get these voices into this room, and that is an oversight. One of the ways that we've done that is by really trying to prioritize choice, and many of these community programs that I think are on the call today also do a really excellent job prioritizing choice so that people can have access to foods that resonate with them and that are culturally relevant.
And maybe I'll just add, well, again, I'll add ditto to what Hillary said, but I'll also say that we engaged about 100 individuals who are food insecure as we were designing our strategy, and really rolled up our sleeves, went into people's homes, food diaries, refrigerators, really trying to figure out what people wanted, and landed in a place of, some people cook, some people don't, for reasons that sometimes it's because they can't, sometimes it's because they don't want to, and tried to come up with interventions that were different based on people's preferences. And then also, as we've been rolling out produce prescriptions, for example, we've been trying to have different food boxes that you can pick based on your preferences and culturally appropriate, hopefully. And it's not easy. It's not, especially because we have a lot of members. We have 12.5 million members. I mentioned we have about 30% that might be food insecure. So it's a lot of people with a lot of different preferences. So we're trying here, and it's going to be a work in progress.
And I'll just add really quickly that all of our meal kits were designed with testing and feedback from our Participant Advisory Council. Our Participant Advisory Council mirrors our program participation. We have about 80% Black women who are participating in the program and about 20% who identify as white. So everyone gets to bring them home on the Participant Advisory Council, test the meals and provide us with feedback, give us suggestions for things that they'd like to see incorporated. And we're also forming our own little test kitchen where they get to come in and cook with us as we look at revamping the meals over time.
Corby, I think you're going to close us up.
That's because we see the scary clock. It says it's 1:30. We see 70 Q&A. That means sign up on our listserv on Food and Society at the Aspen Institute, on Chilpy's listserv, because we are extremely likely to capture all of your questions and make them part of a next session. A surprise to Sarah, but we're committed to mounting one because we love the engagement. We welcome the engagement. We welcome even more you to download and read our research action plan. We couldn't be more grateful to you for joining us today, for Walmart Foundation for supporting this work, and to our fantastic inspirational speakers who guided us every step of the way and will continue to as we disseminate our exciting research action plan into the world, guided by all of their insights, their work, and our excitement about increasing research and the evidence in the future. Thank you for joining us today, and we look forward to seeing you and continuing the conversation soon.
Thank you, everybody. Have a wonderful rest of your Thursday.